Okay, perfect, success. Thank you. All right, so I really wanted to thank the planning committee and Dr. Mishra for inviting me to this very amazing conference. I was listening to the speaker before me. Great conference so far. Dr. Thomas is obviously an outstanding researcher, educator, and endocrinologist, and I'm really humbled to give a talk in his name. So what I'm going to be talking about today is COVID and diabetes, and I know everybody in this world right now has severe COVID fatigue. What I'm going to show is that we are not out of the woods yet, and we still have a long way to go. That's my slides. Okay, why is my... Oh, there we go. I have no disclosures to report. We'll talk about the pathophysiology of the severe acute respiratory syndrome, coronavirus 2. We'll discuss the intersection of diabetes, COVID, and the ACE2. We'll look at the clinical characteristics which contribute to severe disease, and we'll look at some of the anti-diabetes drug regimens that we have and as relevant to COVID-19. So we know that in December 2019, a cluster of atypical interstitial pneumonia cases caused by severe acute respiratory syndrome was seen in Wuhan, China. And exactly a year ago, the WHO determined that this is a pandemic. And this is data from India from recently, about 11 million cases. Fortunately, the number of deaths is not very high. And this is unfortunately data from the United States, 28 million cases with over 500,000 deaths. And this past January, COVID-19 became the leading cause of death in the United States. Fortunately, the numbers of this condition are going down over the world, but we can see a second wave or a third wave coming in through India, through the US. So we really are not completely done with this. So my talk, unfortunately, continues to be still relevant. So in addition to the usual symptoms of fever, cough, upper respiratory symptoms, we know that COVID affects multiple organ systems in the body, the neurological symptoms of headache, anosmia. We have people coming in with acute kidney injury, elevated transaminases, the cardiac problems like cardiomyopathy, myocarditis, and then the endocrine disorders that I'm going to talk about. And there are certain lab abnormalities that portend a worse prognosis in COVID. So if you have somebody with an elevated white count, but the absolute neutrophil count is less than 800, if their CRP is over 100, if their D-dimers are over 1,000, their transaminases are 2 times upper limit of normal, or their cardiac enzymes are 2 times upper limit of normal, all of these are related to a poor prognosis or a poor outcome for these patients with COVID-19. So this picture here is very familiar to all endocrinologists over the world. This is the renin-angiotensin-aldosterone system. We know that the angiotensinogen is ubiquitous in the body, constantly made by the liver. And under the effect of renin, it converts into angiotensin 1. Now, renin is secreted by the kidney, responds to decreased volume, decreased salt load to the kidney. Angiotensin 1 gets converted to angiotensin 2 by the ACE enzyme, which is present in multiple organ systems, but mostly the lungs. What I want you to pay attention to is the receptors. Angiotensin 2 works on the angiotensin 1 receptor, which is basically what causes all the negative effects in the body, the pro-inflammatory effects, the pro-fibrotic, the pro-thrombotic effects. The AT2 receptor, on the other hand, has beneficial effects on the body in terms of vasodilatation, anti-inflammatory, anti-fibrotic effects. Angiotensin 1 and angiotensin 2 are acted upon by ACE2, forming these molecules, the angiotensin 1 to 9 and angiotensin 1 to 7. Think of these as your beneficial pathways or your beneficial molecules. They work on the MAS receptor, causing all these downstream effects here. So the MAS receptor and the AT2 receptor have very similar properties. It's the AT1 receptor that causes all the inflammation and all the negative effects that we see in the body. So how does COVID play a role in here? So we know that the coronavirus has a spike protein. That's what causes binding to the ACE2 receptor. This is the mode of entry of the virus into the cell. Once the virus enters the cell, once it's internalized, unfortunately, there's downregulation of the ACE2 receptor. Part of it is protective so that more virus cannot enter the cell, but part of it is causing issues because now the angiotensin 1 and the angiotensin 2 cannot be downstream. The effect of their formation on angiotensin 1 and 1 to 7, which causes the beneficial effects on the body, is blocked. So now more of the angiotensin 1 and 2 is directed towards the AT1 receptor, which causes all the inflammation, the acute lung injury, the adverse myocardial remodeling, the vasoconstriction. So this is how the virus and the renin-angiotensin system is affected. So if you look at just the top part of the graph here, don't worry about the bottom part, we've already gone over it. So when there's cell surface binding to the coronavirus receptor binding domain, it facilitates entry of virus into the cell. The ACE2 is the one which causes the entry into the cell. It's present in lung, kidney, heart. That's how it causes organ injury. And then there's some data about pancreatic islet injury related to the ACE2 receptor expression causing insulin deficiency. So now what we call it is the renin-angiotensin aldosterone coronavirus axis. This is how it interplays. So we know that both ACE inhibitors and ARBs increase tissue levels of angiotensin 1 and renin. And in the beginning of the epidemic, there was a lot of consternation that there might be increased ACE2 activity and these medications should be stopped in patients. Unfortunately, all the major medical societies came out and discussed the effects of continuing these medications because they do have a beneficial effect on the body. And what we have to remember is that ACE inhibitors do not have an affinity for the ACE2 receptor. So there's no signal that this is going to cause a detrimental effect in the body. We also have to remember that the angiotensin receptor blockers increase angiotensin levels everywhere except the kidney. So the higher, So the higher angiotensin 2 levels are now directed through the ACE2 pathway into the beneficial pathway, which is the angiotensin 1 to 7 and the AT2 receptor. Now the ACE receptor can be like a double whammy because acute hyperglycemia upregulates ACE2, which might facilitate virus entry into the cell. On the other hand, chronic hyperglycemia downregulates ACE2 expression, making the cells vulnerable to inflammation. There's also very good animal data that ACE inhibitors and ARBs mitigate the effects of unopposed AT1 receptor activation. So patients who have cardiomyopathy or decreased cardiac output, they tend to have more ACE2 expression, and the pathway towards the beneficial pathway towards the AT2 and the MAS pathways higher. The three major prognostic factors for COVID-19 happen to be age, ethnicity, and gender. We know that older age is generally a worse prognostic indicator for people with COVID. And in a cohort of over 72,000 patients, peak morbidity was in the 50 to 59-year age group, and case fatality rate was 2 to 3% in this group. However, the CFR went up to 14% in patients who were over 80 years of age. And then the case fatality rate is higher in males, 2.8% versus 1.7%. And there is some data about the androgen receptor being the reason behind it. And we also know that non-white ethnic groups are at higher risk for COVID-related complications, and it's not related to any biology or genetic predisposition. It just happens to be that non-white ethnic groups tend to have more forward or front-facing jobs, or they might be in the restaurant industry, they may be in the healthcare industry, and they're more likely to be exposed to the virus. And if you look at an analysis, it showed that 33% of people admitted to hospitals with COVID-19 were African American, even though they represent only 18% of the sample population. And this has been proven in multiple studies in Europe and as well as the United Kingdom. We cannot talk about COVID without talking about obesity. So we know that obesity is the major risk factor to having a severe outcome when you have infected with the virus. The first one is the restrictive ventilation. Their body habitus is such that they have decreased ventilatory capacity. It's like the Pickwickian morphology that we talk about. And there's data that if your BMI is over 35, you're 1.5 to 2 times more likely to end up with mechanical ventilation. We know that people with obesity have immune dysregulation. There's very interesting data on fatty liver disease. Multiple studies are coming out talking about patients who have fatty liver tend to have 4 times more likelihood of ICU admission and mechanical ventilation compared to age-matched people with diabetes and obesity. We also know that the epicardial fat is a metabolically active organ. It has ACE2 expression, and patients who develop the virus, who contract the virus and have increased epicardial fat, they tend to have severe outcomes related to local myocardial inflammation. And we also know that obesity by itself is a prothrombotic state, leads to more strokes, microangiopathy, DIC. So for every 10 square centimeter increase in visceral adiposity, the odds ratio for an ICU admission about 1.37 and 1.32 for mechanical ventilation. So what's happening at the molecular level? A patient gets infected with the virus, there's increase in inflammatory cytokines, there's lung fibrosis, which leads to ARDS. There's increase in patients, especially with diabetes, there's increase in the reactive oxygen species. Interleukin-6 levels are higher, and this in conjunction with the activation of the renin-angiotensin system leads to increased insulin resistance, hyperglycemia, and cardiovascular events. And we talked about the increased blood viscosity and the vascular endothelial damage. These thunderbolt-like graphs, basically, these represent pathways which are highly increased in patients who have diabetes. So then the question is blood glucose control related to outcomes in patients with COVID-19 and pre-existing diabetes? And I want you to think about it in terms of 3 buckets. The first one is the glycemic control prior to admission. Unfortunately, the data here is very contradictory. There's some studies which showed that a patient who had a high A1C at admission was at high risk for in-hospital death. But then major studies from New York and the Coronado study, which is a large French cohort, showed that there was no association of A1C with mortality. Data on admission glucose and poor outcomes is quite strong. So if you have a patient who comes into the hospital with elevated glucose, they tend to have a poor prognosis. And then patients who have hyperglycemia during hospitalization also have a poor prognosis. And this is especially true for patients with hyperglycemia and no prior history of diabetes. So does this represent stress hyperglycemia that we see in patients with major surgeries, post-bypass, or patients with pneumonia? Or is it by itself is it just a marker for severe disease, or is it that the hyperglycemia during hospitalization also contributes to poor outcome? So the data on this is quite strong that control of glucose does affect the viral course. However, patients who do have hyperglycemia during hospitalization tend to do very poorly. Then does COVID cause diabetes? There are multiple case reports that have come through talking about COVID causing new onset diabetes. And what we have to understand is that there's a bidirectional relationship between diabetes and COVID. And what does that mean? So when you have infection with COVID, there's the initiation of cytokine storm, there's beta cell damage. This leads to worsening metabolic control in patients who already have diabetes. There might be at admission hyperglycemia, which could be stress hyperglycemia. And then there's this question of new onset diabetes in these patients. And once these patients develop hyperglycemia, that leads to poor outcome. The question is, does COVID by itself, does the virus by itself initiate new onset diabetes? And I'll talk about the pancreatic injury. So there's very conflicting data about the presence of ACE2 on the beta cell. Multiple cell lines have shown that there's ACE2 expression on the beta cell, and then there are multiple studies which show that there's very minimal amount of ACE2 activity. So the thinking behind it is that for the virus to cause permanent beta cell loss, the extent of injury has to be extensive. And if you look at data from imaging studies, there is evidence of some degree of pancreatic inflammation, but it's not to the extent, it's not commensurate to the hyperglycemia. Majority of patients with new onset diabetes are not insulin dependent permanently, and these are patients during the hospitalization who have required tremendous amounts of insulin. When we had patients in our hospital with new onset diabetes, these were people taking hundreds of units of insulin a day, but when you see them post hospitalization, either most of them are off insulin or they're just on oral hypoglycemic agents at that point. So it doesn't look like permanent beta cell damage. And we have not seen a disproportionate rise in patients with type 1 diabetes. However, secondary diabetes as a part of long COVID is a possibility, and I'll talk about that. I have a slide to describe that as it's important. So it's not really clear if COVID-19 does cause diabetes, but there are multiple case reports where they have seen new onset diabetes in patients, and these people do present with either diabetic ketoacidosis or even euglycemic diabetic ketoacidosis. I'll talk a little bit about diabetes medications in COVID. So the first one, of course, is metformin. There are multiple mechanisms by which metformin may have a positive effect on COVID-19 outcomes, the most important being the improved glucose control. There's reduction in body weight, less AMPK activation, and the mTOR pathways turned off, anti-inflammatory properties, reduction in neutrophils, inhibition of IL-6 release. And this study recently came out, done by Dr. Shalev and his colleagues. They looked at a retrospective analysis of patients tested for COVID-19 between February 2020 and June 2020. The primary outcome here was mortality. 70% of patients had hypertension, 61% had obesity, and 40% had diabetes. Age, sex, and diabetes were the major factors associated with COVID-19 related mortality. And you can look at this forest plot here that mortality among patients with metformin use was 11% compared to 24% of patients with diabetes not on metformin. And they did adjust for patients who were elderly and had a reduced GFR who could not have used metformin anyway. But despite that adjustment, the mortality in the metformin group was lower. And this is a meta-analysis of 5 studies. Now, the studies are quite heterogeneous in terms of numbers of patients in them, but the main idea, if you look at it, is that in the 6,900 patients that they looked at, the pooled analysis showed that the metformin group tended to do much better in terms of mortality from COVID-19. In the beginning, there was a lot of interest in using DPP4 inhibitors. The Middle Eastern respiratory virus enters the body through the DPP receptor, and it was thought that the SARS coronavirus also had a DPP connection. So a lot of hospitals and health systems around the world started using DPP4 inhibitors. And we also know that DPP4 inhibitors have anti-inflammatory properties. They do dampen the cytokine storm. We also know that they in older patients, they can decrease the cardiovascular morbidity. So that's the reason why there was a lot of interest in this drug. So this study here by Arti in Italy, they looked at 338 consecutive patients. 169 of them were treated with sitagliptin and insulin, and 169 were treated with insulin alone. And the primary endpoints here were discharge from the hospital or death and improvement of clinical outcomes. In the sitagliptin arm, there was 18% of patients who died, and in the insulin alone arm, 37% of patients died. Improvement in clinical outcomes was 60% versus 38%, and hospital discharges were higher in the sitagliptin group. And this is the Kaplan-Meier survival curves showing that the sitagliptin group did better, and the mean glycemic control during hospitalization was much better in the sitagliptin group, and interestingly enough, the insulin doses were very comparable between the two groups. So sitagliptin use has been shown in other studies to improve outcomes. And in the Coronado study, actually, if you look at the subgroup analysis, the people who were on sitagliptin or DPP4 inhibitors tended to have a higher rate of hospital discharge. But this is not ready for prime time. More data is needed for this. GLP analogues, we know they have a major effect on cardiovascular adverse events. GLP receptors are in the kidneys, liver, lungs, and these are the organ systems which are affected by the virus. So there was a lot of interest in using GLP analogues in COVID. The problem is that the data from various studies has not been very helpful in terms of determining whether these are beneficial. The theory behind it is quite solid given the cardiovascular nature of the virus and the GLPs by themselves. And in animal models, there's attenuation of pulmonary inflammation. So there's more to come on this story. Right now, we recommend using GLP-1 analogs in patients who have mild to moderate illness, but not really meant for critical care yet. The SGLT2 inhibitors, so the speaker before me gave a great presentation on heart failure and SGLT2 inhibitors, and so we know that these drugs have a beneficial cardiovascular profile. The problem is that there have been multiple case reports of euglycemic decay in patients with COVID-19. So what we have to remember as physicians is that it's the education of the patient. If a patient has mild to moderate illness, they can keep up with their oral intake, they're not volume depleted, they can probably safely continue these medications, but if there's any evidence of worsening illness, these medications should be immediately stopped. So thinking of the various buckets that we look at. So critically ill patients, I think the only thing that is safe at this point is insulin, the anti-inflammatory drugs, that would be the insulin, the GLPs, and people keep thinking, don't think much about the thiazolidinediones, but they have immense amount of data on cardiovascular protection, even decreasing the cytokine storm. So we have to think of these medications in a newer light. Especially in India, there's a huge amount of patients who could benefit from these medications. I wanted to talk about the long effects of COVID. So patients who survive COVID have a very long recovery ahead. There is data from the first coronavirus in China, which happened multiple years ago, that these patients who survived that virus had long-term metabolic abnormalities. And these are related to post-traumatic stress, binge eating, impaired sensing of hunger, which causes weight gain. There's increased risk of future cardiovascular events. We know that patients who are in the hospital or have an ICU stay tend to have a major impact on their lean body mass. So there's increase in visceral adiposity. So these patients now develop altered glucose metabolism. They have increased insulin resistance, and there might be some data on islet cell damage as well. So these patients, after they come back home, they tend to be in a poor mental and physical health. So multidisciplinary care is very important at this point, which includes physical therapy, rehab, behavioral health therapy, a good dietitian. These people need multi-pronged support so that they can improve their metabolic health, because these are people who may not have immediately developed mortality or morbidity from COVID, but they go on to have a much shorter lifespan. So in summary, we know that diabetes is a risk factor for adverse outcomes in patients with COVID-19. We know that glycemic control is very important, both inpatient and during the time that the patient is at home. Telehealth visits have been a very good way of providing care to our patients. We should look at their cardiovascular risk factors, don't stop their ACE inhibitors or ARBs or statins. And given the impact of obesity, we should really utilize our weight loss programs much more efficiently. Thank you for your attention, and I